So I will introduce my friend Ahmed Sadiq again because he's going to talk now. And he has got a very interesting car which he worked quite a lot on that. I will tell you about the Ahmed Sadiq. I think he's not only a clinician, but he's also academician as well. He's a senior lecturer at Queen's, and he has published quite a lot. If I ask among all our spinal colleagues in London, I think he has published most. And he normally runs a multi-centric trial in order to make the studies powerful. So he involves the multiple centers, main spine center in the city. So, and the talk he's going to give, this is mainly his work because he published a multi-centric trial, and that is now quoted everywhere in the world as a reference. So now I ask Ahmed to come and please talk about this.
Thank you, Irfan, for that very humbling introduction. It is true, I have been an academic in another guise about 20 years ago, where I trained in Oxford and spent probably an equal number of years training as an academic at Oxford, as well as training as a neurosurgeon. But I am primarily a neurosurgeon, a spinal surgeon by practice. But my academic hat principally focuses on doing what's relevant for what we do. It's not about looking at receptors. It's not looking at interesting papers published in Nature or Science. It's about answering the questions that you and I struggle with on a day-to-day basis. Questions which need answers because we are faced with those questions on a daily basis from our patients. Foot drop isn't the sexiest topic today. You've heard about some super incredible conditions, some really innovative treatments, and post-lunch, post-prandial, you're going to listen to foot drop. But I'm going to try and make it a little bit more sexy because foot drop is critical. I myself, as a surgeon, 15 years ago, had foot drop because whilst I was operating on a spinal tumour, I stood in a particularly awkward posture and I crushed one of the superficial nerves in my lower leg. And I thought I wet myself. And I asked the scrub nurse to have a look at my leg. Was the patient's catheter leaking on me? Had I wet myself? Or had the assistant poured lots of wash on my foot? No. And my foot was bone dry, my leg was bone dry, and I had an EMG, I had some investigations, and I had a neuropraxia to a nerve that you all know about that causes foot drop. I spent the last 3 or 4 years looking at this condition because it's incredibly ambiguous. The recommendations across the board are mixed. I lead a very large spinal network in northeast London, and we regularly host conferences like this and invite surgeons from all over the country to come and talk about conditions. And when we pose the question to the audience, how do you manage this condition? I would say 50-50 said surgical, and the other 50 said watch and wait, it gets better. No one could really cite the studies. That one doesn't work, but this one might. You all know what foot drop is. It's just a weakness in dorsiflexion. And for those of you who haven't seen it, in essence, the patient struggles to cock their foot up. That's foot drop. Patients will come to you complaining of stumbling, difficulty walking, struggling with uneven ground, catching their step. It can be painless, it can be painful. Fundamentally, it stops people from exercising. You notice that their gait is different. When you examine them, they're weak in a very specific subset of muscles, and their sensory symptoms are very specific. Ask them to walk on their heels, and they will struggle. Now, like everything that neural, it has many origins, and you can trace it all the way through the spine. Fundamentally, as surgeons, we primarily deal with the L5 nerve as the primary cause of a dysfunction resulting in foot drop. But actually, it could be a peripheral nerve, a second-order nerve, a nerve derived from L5, the sciatic nerve, or the common peroneal nerve, which is the nerve that I injured about 15 years ago. There are even smaller nerves downstream that will give rise to similar symptoms. Briefly, and I don't apologize, there are many slides in this presentation, but for a reason. You always start with the examination, you get an MRI scan, maybe you get a brain scan if it doesn't make sense, but critically, after 6 weeks, if it has persisted and the patient has 4+/5 power, and you want to counsel the patient appropriately, get some neurophysiological studies. Like everything that's digital, over the last decade, there has been an explosion in data relating to this condition. There have been over 2,100 publications in the last 15 years on foot drop. That makes it virtually impossible to decipher what to do. One hopes, with all these medical agentic tools out there, that we'll be able to differentiate and understand, but there are some nuances to medical practice that go beyond OpenAI and Anthropic at the moment from answering. And that's why we're all still sitting here and talking about these things. Because despite Musk's best efforts, we still don't have self-driving cars, radiologists still report MRI scans, and it's likely that everyone in this room will have a full and wholesome career for the next 2 decades without the robots taking over. One hopes. What has changed is publications. Publications, of which everyone in this room will have some or have many of, do not carry the same value or magnitude as they did a decade or 2 ago. I now regularly create very short vignettes on LinkedIn that consistently get tens of thousands of views. In essence, the modern day citation. That's dissemination of information. My papers no longer get hundreds of reviews or hundreds of citations. So knowledge is becoming easier to digest, and that's a good thing. But it does mean if you do not engage with this new method of advertising clean knowledge and advice, you will be superseded by those who don't. And critically, those AI agents that are scouring the data online will form opinions on the basis of what's readily available to them, not what's behind firewalls. So I highly encourage everyone that's involved in clinical practice, and good clinical practice that's classified as the gold standard, to engage with these platforms. So my group, of which my collaborators are sitting here in the audience, we looked at the simple role of surgery in foot drop. We looked at thousands of studies and we looked at thousands of cases, and fundamentally, when we ran a meta-analysis on the prognostic factors of surgical outcomes with foot drop, surgery makes a difference. Surgery within 6 weeks gives you a 6 times better chance of operating. This is a seismic seminal shift in our understanding of this condition. Historically, 50% of practitioners would say, sit tight, conservative management, they're going to get better in painful foot drop. That's clearly not true, because if you look back at the papers published in the early 2000s, about 15% of patients potentially get better if they have foot drop, if they have 3/5 power at point of presentation. Only 3% get an absolute return to normality. Okay? So surgery within 6 weeks makes a difference. Age makes a big difference. That makes perfect sense, because actually the vast majority of patients who have foot drop have, as you've heard, healthy discs that have water that can herniate. Those who are weaker, conversely, seem to do better. But if you think about it, that makes sense, because they have more room for improvement. This is critical, and I want you to all note this. If they don't get better in your physical therapies clinic rooms or in your clinic rooms within 3 months, it's highly unlikely. If they get better within 3 months, it's highly likely they'll continue to get better. If they don't, they won't. If you don't improve at 3 months, you're not going to improve in 18 months. That adage of wait 18 months for the nerve to heal, unfortunately, does not stick. The longer your compression, the worse your outcome. The longer your compression, the worse your outcome. Makes perfect sense. If you compress a nerve for long enough, you starve it, as we've heard, of blood, increased oxidative stress, and neuronal death. Foot drop without pain is very much a terminal sign. That means the sensory fibers running within that nerve have succumbed to the consequences of vascular compromise. These patients do not get better. And actually, if you have a patient presenting with acute foot drop that's painless, that's not a surgical problem. You need to refer them to a neurologist just in case it's another condition, an inflammatory condition affecting the spine. Those who are really weak do badly. We accept that. Functional recovery, 3 months really is the cutoff. If they're improving at 3 months, it's likely they'll continue to improve. Surgical intervention works. 2/3 of patients who have surgery for acute foot drop, that's painful, get better. Now, that was a retrospective study looking at all the data in the literature. And so we then ran a multi-center study looking at all the patients that we have in the UK. Now, these studies are rather rigorous in the sense that their selection criteria and the data points and metrics that we need to collect to come up with an appropriate answer are rigorous. And as such, over 7 centers, over a 24-month window, we identified 75 patients, both retrospectively and prospectively. Now, again, 55% of all patients in the UK-based study, if they had surgery, they got better. And without a doubt, and again, I want you to pay attention to this, each day of delay reduced the likelihood of improvement by 0.2%. We couldn't find an exact timing cutoff. I can't tell you if you don't operate within 6 weeks, they're not going to get better. And again, those who are weaker have greater ability to improve over time. Those who had a weakness of 3, which is an important functional weakness, had the lowest chance of improvement. That seems to be a cutoff. It must reflect a degree of injury to the nerve. This is another important thing. When you're counselling these patients in your clinic, they really want to know, will I go back to normal? And you need to be honest and upfront. Only 1 in 5 of patients will have a return to normal function, i.e. power, in their foot following surgery. 1 in 5. 3% with non-surgical intervention. 80% though get an improvement in their sciatica. And that's important because people struggle with sciatica and there is a pharmacological burden associated with neuropathic pain. So not only does surgery improve the likelihood of motor function, but critically it allows you to wean them off those particularly potent neuropathic drugs that they don't like to be on. Again, age and frailty, as with everything involving the spine and the brain, is critical. Timing is a hard one. It really is a hard one. Everyone asks the same question. Every conference I'm invited to speak in about this particular topic, everyone says, when should we operate? Unfortunately, we just can't say. But what we do know is every day of delay results in 0.2% reduction in a chance of healing. Looking across all the data generated from both our studies, it's quite evident that early referral, early imaging improves outcome. Those who are particularly weak get better, and uniformly, pain gets better with surgery. Thank you very much. Thank you. I'm just going to remain on the stage to introduce the next speaker, if I may. Now, despite our best efforts as surgeons, our scalpels don't fix everything. And more often than not, we need the diligent and expert hands of our pain physicians to save us and help our patients achieve levels of pain relief and function that we can't help them with cold steel. I'd like to introduce my colleague and senior pain physician here in London and at the Fortius Clinic, Damien Smith.
Thank you very much, Ahmed. Just see if I can. Okay, so thank you all for coming. As I say, it's a hot day, no tubes. You've done really well to get here, and I'm really grateful that so many people have turned up. My name's Damien. I'm one of the pain consultants at Fortius. I joined Fortius in June 2015, so 11 years ago now. And then in September 2015, so a few months later, I came across this guy who was 43 at the time. complaining of terrible pain, shooting down his left leg, going into his toe. He had some drop foot. He was demanding that his wife go and get him the meds. He was saying, I want some diazepam, I want some cocodamol, I want some pregabalin, I want some naproxen. I'm sure I've got a huge disc. This is absolutely terrible. It's me, by the way, if you hadn't guessed. Okay. Right, this is me. This is me. I started at Fortius in June thinking everything's going to be fine, and by September I was in bits. I had an MRI scan, and you can see my MRI scan here. I've got this pathetic, tiny little disc here at L5S1, causing this tiny little bit of compression here, but it absolutely floored me. It absolutely floored me. And as you know, it's really common. 80% of people at some time in their life are going to have an episode of lower back pain. And we know that 80% of them start to get better 4 weeks, 90% start to get better by 8 weeks. They don't all need operations. They don't all need injections. You know, we scan them, we make sure there's nothing nasty that we're missing, but we get them good physio, we get them good meds, we get them moving, we keep them active, and it will get better. It will get better. Just to give you a side, but the cocodamol, I took cocodamol because it has a number needed to treat of 2.2, so you only need to give it to 2.2 people before it works in one person. But cocodamol's got codeine in it, which is a prodrug, and we have the cytochrome system in our liver which converts it to morphine. So 30 milligrams of codeine, you convert to about 3 milligrams of morphine. Some people don't possess the enzyme, so some people take cocodamol and go, it just doesn't work. My wife, for example, is an ultra-fast metabolizer. You say the word codeine, she gets pinpoint pupils and passes out. And so there's a real spectrum of people that it works and it doesn't work in. It really didn't work for me. I took cocodamol and I felt terrible. And strangely enough, I took tramadol and I kind of felt a wee bit better. But kind of since going through that very early on in my Fortius career, I've had a lot more empathy for my patients that I see. I do reassure them. I had foot drop for about 2 months afterwards. I kept catching my slippers on the stairs going upwards. But, you know, it's probably helped me in my empathy with my patients. Now, as we know with lifestyle, with treatment options, there's lots and lots of different treatment options for back pain. And I've been asked to talk about injections and medications and things like that. I'm just looking for Richmond Stace. Where is he? Put your hand up, Richmond. Right, Richmond's over there. Because there's not new things, but things that are kind of cutting through that Richmond knows about, that go back to neuroscience, that have kind of cut through to me. And I'm just going to talk a little bit. I'm going to go a little bit off-piste and just talk about chronic pain and some chronic pain scenarios that people get into. So I was listening to a podcast, The Rest is Science, with Hannah Fry. I don't know if you've listened to it. And she was talking about this experiment done by some neuroscientists in Switzerland, which was all about how the brain predicts what's going to happen. And what they did was they put blindfold on a patient, and they put some earplugs on a patient, and they were in a room, so they couldn't see anything, they couldn't hear anything. And they pulled a lever, and every time they pulled the lever, the lever was connected to an arm which touched them in the back. So they pull the lever, they get touched in the back. They pull the lever, they get touched in the back. They pull the lever, they get touched in the back. And then they put a glitch in the system, so there was a delay of half a second. So when they pulled the lever, they didn't get touched in the back straight away. And then the brain had to work out what was going on. And because it was devoid of any other sensory inputs, it started making up what the answer to this was. So people started saying there was someone else in the room with them. They could feel another presence in there. They felt there was this kind of cognitive ghost around. And so what I'm trying to get to is the brain, if it doesn't get all of the information right, it can start not misinterpreting what's going on, but it can give you a different feeling from what's going on. So you can get onto this thing called the free energy principle, which is all to do with the brain working out what's happening. So I know if I put my foot down, I can feel the floor, and if I put my foot down here, I can feel the floor. But sometimes in pain states, there's an imbalance between this. So if I put my finger in a flame, I know it hurts. My brain's kind of reassuring me what's going on. But in some chronic pain states, that's not what's going on. The brain's telling the patient that the body's under threat, the body's going to feel pain. There's an imbalance between what the patient's feeling and what they're actually sensing. So you can say, look, your scan is normal, your blood tests are normal, but the patient's feeling and having this sensation that things aren't quite right. And this goes back to, was it Carl Fritz and Mick Thacker? I'm going to point at Richmond and say, you'll know a lot more about this. So if anyone asks me any questions about free energy principles and things like that, I'm going to point towards Richmond. But today we're going to talk about kind of injections, PRF, which is an electrical treatment, and RF, which is a thermal treatment. As we can see here, we can see images, MRI scans of lumbar disc prolapse, cervical disc prolapse. We can see these axial images, which show compression of the nerve roots on the right-hand side. The nucleus pulposus is what we call immunoprivileged. So it's not exposed to the immune system. So whenever you have a disc herniation, the body recognizes it as a foreign object. So it triggers a sudden immune response. You're going to get a release of cytokines, tumor necrosis factor, interleukin-1, interleukin-6. You're going to have an increased production of prostaglandins and nitric oxide. We know that's how nonsteroidals work. Nonsteroidals turn a membrane phospholipid into arachidonic acid, and then arachidonic acid is converted into prostaglandins. I say to my patients, if I get a pen here, excuse me for a sec. I say to my patients in clinic, I say, what's happening in your back? Imagine this is a nerve, and you kind of do something to a nerve. It doesn't bother it. But if you suddenly cover it in prostaglandins, and you cover it in nitric oxide and you touch it, it fires more easily. It changes the firing threshold. So all of a sudden, the slightest thing causes this shooting pain down your leg. So what happens is we have these altered nerve thresholds. Then eventually, weeks later, if the patient gets into a healing phase, there's macrophage release, absorbing the disc. This isn't a kind of great slide because it kind of talks that there might be a difference between nerve compression and chemical irritation when actually both things can be going on. But when we have nerve compression more as such, then you're going to have more motor signs. You're going to see that foot drop. Whereas if it's a more chemical irritation, so there's a small disc prolapse, there's a sudden release of inflammatory chemicals, the nerve becomes sensitized, then you get more pain predominant situation, and they respond a lot better to non-steroidals and steroidal anti-inflammatories. These are the different injections we can do. We can see here, this is a picture of a caudal epidural injection where we've gone through the sacral hiatus. This is a 3-level lumbar facet medial branch block. This is a cervical epidural. I do all of these at Fortius. I do 95% of them in the patient awake. They walk in, walk out, they go home the same day. I produce all of these images on my op notes and kind of send them to all the referring clinicians. When we do epidural steroid injections, the reason we're going to do it is because there's that irritation around a nerve root, either due to a compression or due to a chemical irritation. So the patient's either going to have cervical pain, radicular pain, lumbar radicular pain, and by putting the steroidal anti-inflammatories in there, it's going to alter the production of those prostaglandins. We said, when you release the prostaglandins onto the nerve root, it makes it fire more easily. This is due to a chemical reaction. We're trying to reverse that chemical reaction. We're trying to stop that chemical reaction. We're trying to stabilize what's going on. You can deliver the drugs, the steroids. You can go interlaminar epidural, you can go caudal epidural, you can go transforaminal epidural. There's lots of different ways of getting it in there. You just want to make sure you're getting it in the right place. The thing about the radicular pain is if you do an epidural or a nerve root injection, a transforaminal epidural, and the patient gets better, they say, that's great, but it only worked for 2 weeks. Then we're not going to bring them in every 2 weeks and give them another epidural. But if they have a positive response, we can move on to a thing called PRF, which is pulsed radio frequency, which is an electrical treatment. Now, in a pulsed radio frequency, you don't have a continual waveform like this, because if you have a continual waveform, the needle gets hot. Whereas if you have this pulsed waveform, then what happens is the temperature stays below 42 degrees. So when you've got a probe next to a nerve root and it's below 42, it's not going to cook the nerve root. But that electromagnetic field induces a neuromodulation, which causes a release of anti-inflammatory mediators and decreases the A delta and C fiber transmission. So PRF is an electrical treatment around a nerve root causing radicular pain. We use the same machine for a PRF and an RF, so people can sometimes get a little bit confused. But with a facet joint injection, the patient comes in, they might have unilateral pain, it's lumbar pain, they have stiffness in the morning, they have pain on extension, they have tenderness on palpation. And I know there was a question about facet joint medial branch blocks. Well, we do a diagnostic local anesthetic only injection, and if they have an 80% improvement, then we'll proceed to a radiofrequency treatment. I know in NICE they often say that you might need to do 2 sets, but getting them in and doing 2 sets is very difficult to do that in the NHS. So we move on to a radiofrequency ablation if a patient's had a positive facet joint injection or a positive sacroiliac joint injection. There's a really, really nice video which was kind of called radio frequency chicken breast, but you can't get it anymore on YouTube. And what they did was they got a chicken breast and they put a radio frequency RF probe into a chicken breast and turned it on. And what you saw over a minute was this kind of area around the tip which started to cook. And it's like shaped like a disc. But what you need to understand is you're working in 3 dimensions. So when you stick it in a patient, you're not actually getting a disc, it's a sphere. And the needle is at the center of the sphere. And so what happens in this case with the radiofrequency ablation is we heat it up to 80 degrees for 60 seconds. It causes a destructive lesion around the medial branches, and that causes a coagulative necrosis, as they say. And then distal to that, we'll get this Wallerian degeneration. But eventually the nerves will regenerate anywhere from 6 weeks up to 24 weeks. Because this is your kind of, often people say, oh, you're cooking the nerve. Don't stick this near a mixed nerve root. You know, if a patient's got motor fibers in there and you stick it in and you heat it up to 80 degrees, you're going to be calling your indemnity straight away. So we use RF for these sensory nerves. We use them for sacroiliac joints. We use them for facet joints. Whereas our PRF, we use them for nerve roots. We use them for radicular pain. As you can see here, with injections, we're injecting local anesthetic. We're injecting anti-inflammatory. We're trying to reverse that chemical process. It can last for weeks to months. Hopefully there's no nerve damage. Good for radicular pain and diagnostic blocks. PRF is an electromagnetic neuromodulation, heated to 42 degrees, can last a few months, and again, we're not doing any nerve damage, and it's for radicular pain. Whereas RF, which is the thermal lesion, we're heating it to 80 degrees, that can last up to 12 months. It does cause nerve damage, and we use that for facets and sacroiliacs. Okay. Anyway, thank you very much.
Thank you, Damien. Incredibly informative talk and some critical key points regarding the difference between PRF and RF, and many spinal surgeons may also struggle with that concept. So it's always enlightening to understand that one is actually neuromodulatory and involves electricity as opposed to simply a slightly lower temperature and less cooking and less effect. And it's not uncommon sitting, certainly in other MDTs, not in at the Fortius Clinic, where I've heard people say, well, why don't we just go to 42 degrees? And that highlights the misunderstanding regarding the electro-neuromodulatory effects of PRF, which is relatively new in the grand scheme of pain management, but it's highly effective. Thank you. It's me again. Slightly sexier topic, right at the top of the spine now. So we've gone from the bottom to the top, and it really is just a very quick whistle-stop tour of cervical spine injuries. Earlier, we heard about cervical radiculopathy, cervical myelopathy. You can badge all of those things in close association with injuries to the spine, but this is very much focused on sport. It's really important to understand what we mean by a spinal cord injury and a cervical spinal injury. An injury to the cervical spine just denotes an injury to the cervical vertebra, as Mr. Malik told you about earlier today, the discs, the ligaments, and or the spinal cord or the neural elements. It can be a minor strain, or it could be a catastrophic spinal injury. And it's critically important to have a nuanced idea of exactly what goes on. About a decade ago, I published an article when I was working on the South Coast with Mr. Ways on this particular topic. And rather interestingly, we used the TARN data set, which is the national framework for harvesting and collecting and analysing trauma data in your locality. And you wouldn't be surprised to hear that on the South Coast, the vast majority of spinal injuries related to either sailing or horse riding. That's very different to what we have seen from the TARN data set for London, which has evolved over the last 5 years with electrical scooters featuring very highly, Lime bikes featuring very highly, as well as what's termed down from London activities. So people who reside in London and either go north or up to partake in extreme sports, kite surfing, etc. Now, cervical spinal cord injury is actually devastating. It's devastating because it has both physical, psychosocial, and economic implications to society, but critically, significant implications to patients. The direct lifetime cost of sustaining a cervical spinal cord injury is not insignificant. We're talking millions, depending on the patient's age. There are about 1,000 sports-related spinal cord injuries involving the whole spine in the UK. And unsurprisingly, there is a bimodal distribution. The young, understandably, because the vast majority of them play sports, and those who take up sports in later life and maybe push themselves a little bit too hard. And understandably, the aged spine is not as tolerant as the younger spine at accommodating for biomechanical force and stress. So when we focus down on sport specifically, how rare is it? To be honest, it really counts for a minor percentage of all the athletic activity-related admissions to hospitals. However, spinal cord injuries account for about 10% of all admissions with a diagnosis of spinal cord injury to hospital. What are the clinical consequences? They are not insignificant. Quadriplegia, permanent disability, and life-threatening complications. It's not just about not being able to move your arms or legs. It's the disruption to the sympathetic and parasympathetic nervous system, as well as all the other complex neurological functions that your spinal cord's involved with. If we miss the diagnosis, it can be catastrophic. And not all injuries are as a result of significant trauma. And actually, if you look at the data, some of the most common causes of spinal injuries to the cervical spine are as a result of a fall from standing height. So you don't have to be abseiling down a mountain or kite surfing on the south coast. You can simply have a fall on the pitch. There's always the question of return to play, and we'll get to that. You can broadly break down the injuries into 6 subcategories, of which we've touched upon already, but I'll briefly go over those. The first of which relate to spinal fractures and dislocations. The others relate to the different columns of the spine, which we've heard about earlier today. The posterior tension band, which is everything around the back. The anterior tension band, which is everything around the front. And compression fractures, which relate to the bony elements, which we've heard about in our neuroradiology talk. And then the classic burners and stingers, which is very common in rugby and American football literature. And then critically, what we've heard about earlier today when Gordon spoke, cervical stenosis and discal herniations, which I will glance over briefly. Now, fractures and dislocations can be catastrophic. We saw a similar picture earlier today that Mr. Malik put up of an odontoid peg screw. Thankfully, we don't really have spear tackling in rugby, and there's been a significant movement away from it in American football. But this really can be significantly catastrophic to patients, and that's why there's been a big drive in specifically contact sports, which involve helmets, non-helmets, and direct head-on collisions with your competitor, that it should be avoided. This is a highly unstable fracture when it relates to sports. Some of you may have seen patients who have peg fractures that are stable in the community, typically seen in elderly patients who've had a fall and may or may not be managed in a collar, depending on the type of injury. But the injuries that are sustained by athletes are unstable because they involve a significant disruption in the ligamentous complex in and around this bone. It's incredibly heterogeneous as a group of injuries because we're talking about the upper cervical spine. Some athletes do not survive this injury. If they do survive it, they will typically earn themselves a piece of metalwork that will bridge the fracture, and one would hope would reduce the likelihood of any potential neurological sequelae following the primary event. Slightly more common, and some of you may have come across this, and we'll take the clinical vignette of a 25-year-old rugby player who in the scrum is squashed and pushed down headfirst into the ground. And what happens there is their neck is loaded axially, but they're also flexed, and there may be a rotational component to this. And what they end up having is a fracture dislocation or a disruption of the facet joint complex. And a rotatory subluxation at the facet joint complex, typically at a junctional level between C7 and T1. We heard Gordon talking about 6-7 being a very common problem and C7 being a common problem because typically the junctions within the spine are the regions where patients are at most risk. This patient in particular, he was caught up a bit like this, and some of you may see between C7 and T1 on the MRI scan, there's an area of high signal, there's disruption of the posterior ligamentous complex, and if you look at the CT scan, you can see widening of the foraminal space and perching of the facet joint just there. This is not an injury that can be managed conservatively, and this patient earned themselves a 360-degree fusion. More commonly, another clinical vignette, 30-year-old riding a bike. Doesn't even have to be up a mountain or down a mountain. It could be on a cycle lane in South London, and someone pulls out in front of them, and they're thrown off their bike, and the point of contact is top of the head, and they can sustain a compression fracture. Depending on the integrity of the ligamentous complex, these patients may get away with just having a collar and conservative management. But it really will depend on the classification of the fracture, the stability, and the neurological compromise. The next clinical vignette relates again to rugby, and particularly during the scrum. 19-year-old, primarily just in practice, such incredible force results in a distraction extension injury to the neck. What you can see here on the CT scan is a fracture dislocation from one vertebra across the other. On the MRI scan, you can see complete disruption of the disco-ligamentous complex, the soft elements, and you can also see significant cord impingement and compression. This is a highly unstable injury and will result as a consequence of being put in this position and having 6 men pushing against your neck. It can be catastrophic, and often is catastrophic when it occurs. If the patient survives, inevitably they may have significant neurological disability, but they will require spinal surgery because they need to be sat up, they need to be nursed. You need to minimize potential lung complications. And in order to do that, they earn themselves a 360-degree fusion. Mr. Grahovac, who's in the audience, actually performed one of these earlier today at King's College for a very similar scenario. Now, more commonly, and some of you probably come across these, are the burners and stingers in athletes. And really, they are neuropractic injuries that are temporary in nature and are a result of a compressive force or a traction injury to an extraspinal nerve. And the patients will complain of burning, sensational paresthesia. 30% of rugby players in a season will be affected. And over 2/3 of all American footballers over a 4-year window, i.e. a career, an active career, will suffer this problem. And these are classically sudden as a result of impact, contact, or traction. They'll have burning and stinging sensation, tingling, always unilateral but non-dermatomal. They don't follow a dermatome because they arise as a consequence of an injury to what? The brachial plexus, more often than not. And they are literally stingers. They last seconds to minutes. Patients recover. If they don't recover, you need to revert back to what you heard in the earlier talk about cervical radiculopathy. They are traction, they are compression, but traction is the most common method, falling onto an outstretched arm during a tackle. They can also be direct compression. Contact like that into this zone here compresses Erb's point, which is a compression point across the brachial plexus, and this is probably the commonest mechanism in the UK. It can also be due to foraminal compression, so a hyperextension and lateral bending narrows the channel through which the nerves exit from and affects a nerve root directly. Red flags, bilateral symptoms, persistent weakness, and recurrent episodes or delayed recovery. You need to loop back in your algorithm and think about cervical radiculopathy or spinal cord injury, or potentially instability. Return to play, and this is a commonly asked question. they have to have complete return of full strength, full range of motion, and resolution of symptoms. No return if it's a recurrent problem, because fundamentally there's probably something underlying it. A persistent deficit, that's a no-brainer. You do not put a player back on the pitch if they have a deficit. And if you suspect spinal cord dysfunction or injury, i.e. more than one limb, then that player needs to be pulled off. There are some national guidelines relating to this. Cervical spine stenosis, which Gordon very kindly touched upon, in athletes is a critical thing to bear in mind, because as the athletes age, over time they have a hyper-exaggerated aging process because of that repetitive loading on the facet joint complex, the disc space, and the disco-ligamentous complexes. So they age primarily a little bit prematurely because of the loading that we've seen. There are lots of ratios and interesting studies that show if you analyze the nature of their anatomy, you can do propensity risk analysis and say this one is more likely than this one to have that. But fundamentally, you just need to be aware of this. Disc herniations are really common in rugby. Tackles, rucks, lots of axial loading, hyperextension and flexion, and the scrum forces in the front row increased interdiscal pressure, result in annular tears and disc protrusions. Thank you very much. So back to my emceeing, we heard about the role of pain medicine and its function at solving the problem surgery can't fix. Really the next part of the armamentarium within the management of the spinal patient is the sports and exercise doctor. They are the doctors that get patients doing or going back to doing what they've come to see you for. Because fundamentally, patients don't come to see us just to have their discs removed or have the pain treated. They really want to get back to doing what they love doing. One of London's most senior sports and exercise doctors, John Rees.
Thank you very much for that. Senior, it's kind of two-edged, isn't it? Older ones. Thank you very much. There's a couple of brilliant talks. I've really enjoyed listening to them. And I'm pleased to say that at the outset of this, so at the start of talks, you often have disclosures, don't you? And I'm very glad to disclose I have no neurological injuries. So thank you very much for that. Now, I've been at Fortius. I'm in my 14th year now, and it's been a great privilege to be there. And the great thing is, having worked here for that length of time, it's a family, and I realise I'm the support act. Okay, the physicians are the support act to the pain management, the great injections, the surgeons, etc. But we all work as a team, and there's nothing been more inspiring over this time than working with really brilliant and many world-class colleagues. So if you send someone in, someone knows someone who will sort the patient out. So we do work very much as a family, and it's been a growing family at that. Okay, so I'm going to talk about some sporting injuries, particularly adolescent, and I'll illustrate that with some clinical cases as we go through. Right, okay. So, first up. So, the adolescent sporting spine. So, this was a referral to me from a general practitioner. 13-year-old sporty schoolboy. So, with a 4-month history of low back pain. So, maybe not doesn't seem too bad. 4-month history of low back pain. This guy is like many children these days. His diary is packed. Okay, he's an academy trains with academy football. Okay, also enjoys playing rugby for the school and cricket to a decent level as well. One of the things I do routinely in the history is what do you do each day of the week? What do you do on a Monday? What do you do on a Tuesday? Etc. And he was only having 1 day off per week when he wasn't doing sports. And often there may be 2 or even 3 sports activities in a day if he's doing PE, sports at school, doing the team sport, etc., etc., etc. And with the way academies have gone, if you're in a football academy, my son plays a development academy level in Cambridge, it's intense. It's not just a little kick around. It is intense. People are competitive, and it's a lot of exercise. So what is the load that people are getting? Okay. And these are sort of self-selecting kids, and they'll push through. They want to play. They'll push through. There's a whole talk on if a kid doesn't want to play, and you can go into that. That's for another time. But generally speaking, they're motivated and they want to push through. So presented to his GP a 4-month history of low back pain, so a long term. On examination, let's say slight scoliosis, normal range of movement, slight discomfort, L5S1. Okay, 13. And this is his X-ray. Okay, so we can see he has a pars defect, an established pars defect, and he's got an L5S1 spondylolisthesis. He's 13. It's not a great place to be at 13, and that's so the message from the young. If you've got someone young, back pain, it's less common in the young, and someone doing that amount of sport. Okay, and his dad, he came up to me and said, "Oh, he's got a fracture. It's going to heal, isn't it?" It's not. It's established. He's got that for the rest of his days. Okay, so back in my day, I think you would do some gymnastics. It was a more rounded education. I think rugby, football academies. There's so much to get good. You've got to specialise super early, and that's a problem. I'm not sure what we can do about it, but perhaps be aware of it. Okay. So this is an MRI of the same child here, and we can see his established defect here. And this is a vibe sequence, and it shows in more detail. I'll talk more about vibe in a minute. It's pseudo-CT, and we can see established bilateral pars defect. Maybe it's 13. Okay. Right. So we've heard about trauma in the last talk, and to a certain extent that was major trauma. My trauma, or for this talk, very much repetitive trauma. So stress injury of the pars interarticularis. And you can see, it's going to be under stress here. It's repetitive lumbar extension and rotation. It's most commonly L4-5, and with a bilateral pars defect, there's a risk or possible inevitability eventually of progressing to spondylolisthesis. It's a different type of spondylolisthesis to a degenerate. This is a sort of a repetitive trauma cause. Why does it happen in adolescence? Well, one of the reasons is these are children or adolescents. They have not reached skeletal maturity, and so we're putting forces through, and they're not skeletally mature, so they're at higher risk of injury than adults. Okay. And so what are the specific sports where we should pick this out? So fast bowlers, sort of par excellence, and there's a huge development in literature on the development of pars stress injuries in fast bowlers. That can happen throughout careers and can effectively be devastating. Gymnasts, ballet dancers, but it's not just linked to those sports. We see it in football, in particular at the academies, hockey as well, see it in rugby, tennis as well. And to get good at any of these sports, to get really good, that is, you've got to do a lot. Athlete-related factors, so these are some of our extrinsic factors, intrinsic factors, early specialisation, growth spurts. Actually, a lot of people have got core weakness. So that's something to work on, something we can do something about. Okay, so another history, 3-month history in a 15-year-old gymnast of niggly back pain. It doesn't sound that much. Okay, training regularly, probably training through it, increased pain after competition. Okay, so it's 12 weeks. You know, who doesn't play with a niggle? And we can see on the MRI a hot pars L3 in that area, and this is the axial sequences, and we see we've got a unilateral, looks like almost a normal on the left side, looking like it's going through to a complete established pars injury. So what should we be doing in terms of imaging these people? Well, the first thing is obviously to recognise it, and if you've got a high-risk individual, someone who's doing a lot of sport, to think, could this be a pars injury? MRI is always the first line. Yes, the X-ray in the 13-year-old, it came through from his GP, and that would be available, but ideally MRI to try and pick these injuries up early, because they can detect early bone stress. And you sort of worry with, if you go back to that 13-year-old, if you had an X-ray is normal, what does that mean? It sort of doesn't. It means they may still be at risk of the injury. A lot of my patients are young adolescents. MRI avoids that radiation issue. Okay. Now, thankfully, this was mentioned earlier in the imaging talk. I'll talk a little bit more about it. A question came up about what's the imaging that you do for a VIBE, what's the imaging you do for a pars injury. And for Siemens, it's called VIBE, volumetric interpolated breath hold sequence. Slightly easier is T1 weighted echo gradient, or just a better scan for cortical bone detail, or just a VIBE sequence. GE call it something different. Now, what that gives you is it improves the fracture detection. The CT is the gold standard for a fracture, but a VIBE CT gets us very close to that, and it avoids radiation. You can visualize cortical defects very clearly, and it basically replaces CT. Okay, so I can't remember the last time I requested a CT for a pars injury, but we would do it. It's a longer sequence, takes longer, but the information you get and is validated. And it means you can sequentially scan patients without the worry of radiation dose. Okay, this is an example. So on the left, sagittal section, we can quite clearly see a pars defect here, and this and on this side, this is a VIBE sequence for our patient before, and I haven't got this sequence, but the slices for a standard MR are relatively thick, and these are tiny, tiny, tiny. So it gives you great information. It sort of looks like a CT scan, and for many injuries, you can use it to replace CT. Okay. Another example, 14-year-old fast bowler, 4-month history of back niggles. He plays cricket for school and club. Now, the club might be monitoring how many overs he's doing, but they're not necessarily taking into account what he's also doing at school. And I guess a bit of a theme developing here. So he developing pars injury, and he's actually got established bilateral pars injury. Okay. So if you've got an incomplete, what's the management if it's not an established fracture? And if a fracture becomes established, then actually the pain goes. So they tend to be only painful when they're trying to heal. So it can take 8 weeks, maybe even longer sometimes, for the bone stress to heal. And your challenge, adolescents, your challenge is keeping them off their sports and off movement for that time. And it can be, try telling kids to do nothing, it can be difficult. Bracing only very selected patients, maybe if they've got a bilateral acute pars injury. Avoid extension loading. And consider the wider context of the injury, the nutritional status, how much activity they're doing, whether there's evidence of RED-S, relative energy reduction, the training load, what they're doing, etc., etc. Are they going through a growth spurt, etc.? We can come on later and discuss what bone medications we could potentially use, but if someone's growing, the medications, vitamin D, good nutrition, that's probably about it. So, there is a sort of a whole MDT here about why that's happened, and that's beyond the scope of this talk, but just to pay attention to that. Okay. If you've got someone who's recovering now, what can you do to help get them better? And remember, once we've seen some healing across the pars injury, it doesn't mean they're fully fit. It doesn't mean they can go back to playing fast bowling, playing their elite sport. Front crawl or backstroke, good for fitness. Static bike, upright, not bending forward, not carrying a whole load of heavy books to school. Elliptical trainer, ultimately progressing to running, and then eventually cutting. The core training is they've got a lot to do, and it's pretty dull, isn't it? But they need isometric, progressing to isotonic, balance work, double leg and single leg, cable pulleys, T-Rex harnesses, etc. But long term, it's a great idea for these people to keep the core strong. Okay. Very quickly, a couple of other conditions. This is a patient came in a couple of weeks ago. 17-year-old, looked like a massive 17-year-old, but really a child in a man's body. He was a weightlifter, and he presented with back pain, Schumann's disease, minimum of 3 vertebrae affected, where we have crushing or anterior loss of height. Can be associated with disc degeneration and Schmall's node. Can eventually lead on to a postural kyphosis and problems later on in life. This is his scan. So anterior wedging, active small nodes, disc degeneration. This guy's 17. So it's kind of a challenging consult. He said to him, well, you need to lift less weights. That's what he does. But, or at least lift less weights until he's reached skeletal maturity. He looks mature, but he's skeletally immature. Okay. Activity modification, posture correction, core strengthening. You might want to do some bloods to make sure there's no evidence of a discitis. So, a summary slide for back pain. Back pain in a child and an adolescent is different to an adult, where it's ubiquitous and serious pathology. Sorry, Damien is uncommon, thankfully. Okay, and we're more relaxed about this, but try. You see an unselected group of people, try and pick out the bone stress injury, neoplasm inflammatory arthritis, relatively common. It's a less common presentation in the young. Very quickly, we've got a marathon coming up, another vignette, and I had a 42-year-old guy. He had an old T12 trauma from, it was a quad bike. That's another good way of spinal injury. But he then did a marathon, developed crush fractures post-half marathon. So yeah, repetitive, but I'd call this low trauma. He had a history of hypermobility. All his investigations were fine. Osteopenia, it doesn't seem too bad in a 42-year-old, but he's had a fragility fracture. He wanted to keep on running. He wanted to keep on being active. This is his MRI, and we went through. He had a SPECT CT to ensure nothing else going on, but his problem was pretty basically there's altered biomechanical loading in his spine and osteopenia. He wanted to get back to running, and we went to one of the newer medications, not a bisphosphonate, which sort of holds your bone density, but I put him on teriparatide, which is anabolic and increases your bone density. You wouldn't get it on NICE. That's a funding issue. He had 2 years of PTH, and it's particularly good for lumbar spine bone density, and he improved his bone density probably by 1 unit. It's very significant. He's happy. He's back to exercise. All right. Finally, last case. So, 28-year-old recreational athlete injured playing rugby, presented with thoracic, spine and hip pain. His symptoms were worse with offloading, worse when he wasn't playing. And a scan, and this is his scan, and he had enthesitis in his spine and sacroiliac inflammation, severe, significant, and costochondral inflammation as well. You get ankylosing spondylitis. So just because they might be a rugby player, but they might present with something else. And you know, I rely on someone out there having a magic moment of what might be going on. Okay, and you know, I appreciate how difficult it is in physio and general practice because you see an unselected population. So, and he did really, he actually had psoriasis, B27 positive. He did really well on anti-TNF medication. So I'm a sports doc, but I do rheumatology as well. Okay, so MRI pitfalls for inflammatory arthritis or for past injury might not be set up to particularly look for it. So when you're writing on a form, let the radiologist or the radiographer know what you're looking for. Otherwise, you might not get as good an answer as you could otherwise. And if you've got someone who's not improving, you're not sure what's going on, and I am acknowledged Paul Cohen, screened them, you know, check eyes, skin, relatives, early morning stiffness, nails, dactylitis, enthesitis, and a good response to anti-inflammatories. And if you do that, you won't miss much rheumatology. Thank you very much.